Hello and welcome. Thank you so much for spending your Tuesday evening with us. My name's Alistair Burgess. I'm the manager of the Primary Healthcare Improvement Team here at the Northwestern Melbourne PHN, and I'll be helping facilitate tonight's session. So this is session 2 of our COVID education series, Managing COVID Positive Patients in Primary Care. Before we continue, I want to make sure we take a moment to acknowledge the traditional owners of the lands on which we're meeting today and pay our respects to their elders, past, present and emerging. Just a quick little bit of housekeeping to make sure we're all on the same page for tonight's session. All of you dialing in, you're currently and you will remain on mute for the entirety of the session, but we absolutely encourage you to still communicate with us and participate in the session with providing comments and questions. You'll notice that you have a toolbar, often sits on the right-hand side of your screen, depending on which device you're dialing in with. On that toolbar, there's a question box, and we encourage you to use that box to actually type your questions in, and we'll be taking note of those questions and trying to ask them at certain points along the session. I think we've got a break midway where we can stop and ask some relevant questions there, and then we've certainly allowed a fair amount of time at the end for lots of questions and discussions about everything that was covered in the session. There's also a chat box that you'll see on your toolbar, so that's a really important one to use if you're having any particular issues. Our behind the scenes person, Madeline, she'll be back there chatting to you on the chat box if you have any questions or concerns, so please don't hesitate to use that. And lastly, for housekeeping, as with all our education sessions, we will provide you with a post-session email, and this will include some important resources that might be relevant to the session, and also a very important evaluation where we ask you about what you think about the session, what other things you would like us to cover in sessions going forward. So if you can take a few moments to complete that after this session, that would be greatly appreciated, because we really do take a look at your comments and see if there's any extra things or support that you require from us. Just a couple of extra things on COVID before we delve in much deeper. We like to remind people about how to stay up to date with all the changes that continue to happen in the COVID space in primary care. We've labelled them the 5 S's to make it nice and simple. So staying up to date, obviously making sure you're checking the quick reference guidelines in the DHHS website. Really encourage you to consider, if you're not already receiving our updates from the PHN, to really consider signing up for those. So we spend a lot of time and put a lot of effort into taking all the latest daily information and condensing it down into what we believe is most relevant for general practice in our region, and we send those out usually in what we call an e-blast form. So if you're not receiving those, please let us know. You can do that with the post-course email, and you can sign up to that or speak to your relationship manager that manages you at your practice. Make sure you subscribe to the Victoria Chief Health Officer alerts. There's the hotline number for the DHHS, and if you haven't already, make sure you check out the COVID-19 pages on the Health Pathways websites. There's some really specific COVID pathways that are being constantly updated to keep everybody informed of the latest information and the latest processes around managing COVID. Again, we can help you get it set up with an automatic login to make that nice and easy for you to use in your practice. Just to let you know, I mentioned that this is part of a series. So at the PHN, we're really wanting to support primary care in our region as we continue with the COVID pandemic response, and continue with sessions like these on a regular basis. We're trying to hold them approximately every fortnight, and we've got a number of different topics in the pipeline that we're looking at getting set up and running, and these are just some of the ones that we've got in the pipeline on the way through, and we're absolutely more than happy to hear your suggestions if you think there's anything in particular that you want us to cover or delve into a little bit more. So keep an eye out for these sessions coming up. We'll absolutely let you know when the dates and times have been confirmed with the speakers and when you can register for those. Having attended tonight's session, we will make sure that you directly receive notification of when the next session will be and what that topic will be, just so you are aware and can register if you wish. And lastly, that's enough from me. I'm going to hand over to the experts now. So we've got 2 main presenters tonight. Dr. Nicole Allard from cohealth. She's a GP and has also been one of the clinical leads on the COVID positive care pathway project. And we've also got Dr. Alistair Miller from the Royal Melbourne Hospital. He's a respiratory and sleep physician and clinical lead as well. And then we've got a couple of extra people with us. Bianca Bell from the Northwestern Melbourne PHN. She's the Director of the Primary Healthcare Improvement and really been heavily involved in helping set up the support system for primary care in our region. So we'll be here to answer any questions that you might have specifically around the PHN's role and in how we're helping with this response. And we've also got, that's Dr. Karen Linton, I should have put that there. She's a GP and also one of the clinical leads for this model and this project. So we're also here to answer questions as well. So that's enough for me. I might hand over. I think we've got Nicole up first. Is that right, presenting?
Yeah, that's right. Thanks, Alison. Hello, everyone, and welcome. There's 93 attendees, which is fantastic. Apologies, I didn't seem to manage to get my webcam working, so I'm just going to be a voice without a picture. So tonight we're just going to go through the talk about managing COVID positive patients in primary care and give you an update on what's happened with the pilot. It's only been 2 weeks since Alistair and I presented, but it seems a lot longer actually, if I think about it. So we'll try and update, and we do want some time for feedback, and we're going to have a bit of a stop midway and have some feedback from GPs. Some of you who would have been involved in the program, and I'm sure there'll be many suggestions about how we can go moving forward. Okay, my slide, next slide, Madeline? Okay, my slide's not advancing. I think I just also wanted to acknowledge the traditional owners on the land in which we meet and pay my respects to Aboriginal people and acknowledge their continuing and enduring presence, and that this land was never ceded. So none of us have any conflicts of interest to declare. So tonight we're just going to cover an update on the epidemiology, an update on the pilot, referencing, how we manage patients in primary care, challenges, successes, Redcap feedback. And then tonight, Alistair is going to present on the medium risk pathways and also talk about post-COVID care, which I really see as the next challenge in general practice. So this was from the Australian government. So from yesterday, so at the moment we've got basically a second wave, which is essentially Melbourne, with a little bit of smattering from New South Wales, and most of the deaths and hospitalisations have been in our state. We're certainly seeing the numbers come down, which is very encouraging. However, we've got to remember that there might be a little bit of a testing issue, as in people aren't getting tested as much. So I think we're certainly over that second hump. But this is a very tricky virus, and so we've got to sort of be vigilant about where it might pop up next. Latest Victorian numbers, we've had a big decrease in the amount of active cases, down to just under 4,000 from nearly 8,000 at the beginning of last week. So this is people as they are cleared from isolation, and asymptomatic people, symptomatic people, people who have hospitalised. So we've still got quite a few active cases in the state. And if you look at our region, this is just by postcode, it's still essentially affecting the northwest. So this is all available on the DHHS website, and you can sort of drill down into your own relevant postcodes. And you kind of see that even within local government areas, there are particularly hard hit postcodes. I didn't include the whole of Western Melbourne, but just to give you an idea about what's happening. So COVID-19, 85% of people can be managed in the community. They have mild disease. There's quite a large number of people who are either asymptomatic or so minimal symptoms, and that's much more likely if you're young. About 15% will require hospitalisation, so need oxygen, and about 5% will require ventilation. And you're much more likely to need hospitalisation if you're older or you have significant comorbidities. And when we're looking at treatment, there are some benefits, but the big gain really has been dexamethasone reducing both morbidity or mortality in people and reducing the need for ventilation. So the red flags, this is from the Health Pathways site, that we have to really be mindful of in general practice: a new or increasing shortness of breath, chest pain or tightness, syncope or near syncope, altered mental state, weakness, lethargy, hemoptysis. And we've also added consistently missing meals because that was associated in a study with much poorer outcomes. I think the comment has been made in the past that these are very red flags, most of them. Like, not many people would disagree that altered mental state is a red flag. I think the weakness and lethargy is particularly of interest to us, that sometimes people can just be getting weaker and weaker and unable to do what they could do the day before. Simple tasks like walking to the bathroom are getting harder. That's an indication of someone whose oxygen's dropping, and we need to consider sending them to hospital. We have a national COVID evidence task force that has constant review of the evidence in COVID. There are now, I think, in excess of 15,000 publications related to COVID, and they are forming clinical guidelines, living guidelines, clinical flowcharts, and reviewing evidence, and very much encourage us to think about the clinical questions relevant to our practice area, so they can actually be addressed. Also like to draw your attention to the home care guidelines for adult patients with mild COVID-19, which the college just released this week, I believe. So this is basically based on the evidence-based guidelines of the National Task Force, and it's very consistent with a lot of the decisions we've made in the pilot, and I just draw your attention to it to have a look. It doesn't really give us much in terms of direction, especially on oxygen monitoring, which disappointed me a little bit, and probably doesn't really drill down into some of the special situations that we've seen in COVID-19. But it's a start, and it's a start for the college to have guidelines in this area. So this is from those guidelines, and it's a reproduction from the National COVID Evidence Task Force, really, and just reminding everyone what is mild illness. So mild illness is what we are thinking about managing in the community. Moderate, severe and critical illness are all requiring hospitalisation, because moderate illness requires oxygen, and then severe illness and critical illness, obviously, that's a bit self-evident. So what is mild illness? So no symptoms, or people who are asymptomatic, or mild upper respiratory symptoms. People can have cough. They might have a little bit of shortness of breath on exertion, but they're not breathless with minimal exertion, and they're not meant to have a reduction in oxygen saturation. Obviously, that's a little bit problematic because most people we would evaluate in general practice don't actually have oxygen saturation meters at home. Another really good resource is this from Trish Grenell's group in the UK, which is the remote consultation for COVID, with similar red flags, and just a nice sort of flowchart for the visual learners out there. So what is the evidence for monitoring? The bottom line is there isn't actually much evidence for or against monitoring. There's no evidence for the use or not of oxygen sat monitoring. That was reviewed by the task force about 2 weeks ago at our request. And deterioration can be abrupt and most often occurs in the 2nd and 3rd week. So the consensus recommendation in our current guidelines is that people should be monitored for markers of clinical progression, especially on day 5 to 10 after the onset of symptoms. And I think it's a very important practice point that when we're talking about COVID and we're talking about days, it's always onset of symptoms. It's not when the person had their test. It's not when they were exposed. It's day 5 to 10 after the onset of their first symptoms. So just moving, and I'm not sure in this group how many people are outside the PHN area who've joined tonight, but this is the pilot that we've done with Melbourne Health. So we've had notifications coming from cohealth, Melbourne Health and the department into assessment centre who look at clinical and social and welfare needs and risk stratify individuals into low, medium or high risk. High risk being those who require inpatient care, low risk back to their GP if they have one, try and find a GP if they don't, or use a cohealth GP if neither of those two things are possible, especially for people with no Medicare. And then straight into the medium stream if people are higher risk, including comorbidities or age over 60. Now, within all of this, there's been a lot of flexibility with Melbourne Health, and it's obviously about patient consent in the process. So, you know, we've followed the risk stratification, but then also taken into account individual patient factors. This is the current, what we're asking GPs to do if they do take on a COVID case in the community. So days 1 to 4, which to be honest, we almost never get the notification this early, so it's almost irrelevant, but just to make at least one point of contact. But then day 5, and we've got until 14, or you can say until resolution of symptoms, second daily consultations at least. Now, some GPs might choose to do daily consultations, and I think we're very aware that the frequency can be based on clinician discretion, patient health literacy, and the capacity of the service. I just wanted to show this, and I apologise, both of the next 2 slides have got a little bit blurry, but the vast majority of patients that we've seen in the program fall into the aqua band, which is low risk patients suitable for care in general practice. And our group that have been hospitalised have also stayed pretty consistent all the way through. And the grey band at the top is people that we're discharging. So we're discharging more and more, obviously, because we had the majority of patients were diagnosed a couple of weeks ago. And this is even worse, and I do apologise, but we have various reasons for discharge, including withdrawal of consent, being unable to contact, or the client was in residential aged care or in hotel quarantine. So what have our challenges been? Our challenges have been, the broader program challenge has actually been data coming from DHHS, the timeliness of that data and data quality. And this is something that has consumed a lot of time on behalf of the group who've been involved. We've sort of fixed that, but this has made a direct impact on the work that we've been able to do, and it's reduced the capacity. We thought we would be seeing many more patients than we ended up seeing, and mainly because of that feed of data from the DHHS. What have our challenges been? We've had a lot of international students who have no Medicare and variable health insurance, so often don't have health insurance for primary care. We've actually had a very high percentage of people with no GP, both international students and young people who don't have a GP. Linking people to care in general practices has been challenging. As we all know, a lot of GPs are part-time. We're trying to feed a patient into a particular GP, but in fact, we really probably need to talk to the whole practice. I think our handover to GPs has at times not been as good as it could have been. And we're working on processes to improve that, especially with comments from GPs who've been participated. And we also got, especially last week, we got quite a few aged care referrals and hotel quarantine referrals, and basically kind of spent a bit of time working out that that's actually what we were getting, and that was probably related to some screening done and the way the data fed in from DHHS. So I'd say the successes of the program is that we've assessed over 400 people in terms of the medical status and social needs. We've identified and mitigated quite a few isolation issues. We've linked people to care in general practice. There's a single point of entry into our medium risk pathway, so you can, stream people straight in, and then the Melbourne Health crew can decide whether that goes into the virtual ward or hospital in the home. We've connected to hospital in the homes actually across Melbourne because people have come in from out of area. We've hospitalised quite a number of people who were deteriorating in their second week. And because of the timeliness issue in the data, we did actually most often see people from day 5 onwards. So we weren't really getting the early referrals unless they were coming from cohealth or from Melbourne Health. We've been able to facilitate the release from isolation for people who'd met the criteria. And I think we have worked together as a group to promote the need for care of people with COVID in different levels of the department, Safer Care Victoria, the Public Health Unit, and so on. I wanted to talk a little bit about Redcap. For those who haven't taken on one of our patients, I apologise. This will be sort of a little bit abstract for you. But Redcap is really tracking the metrics of the pilot program and feeding back to the department. It's not a clinical management system, and it's a data sharing point with the Royal Melbourne Hospital, and GPs have been sent links every second day to follow up their patients. Now, it exposes problems, especially in terms of, emails in general practice. I'm not talking about the identity because it's a secure link, but just more that, a practitioner might not be there and then come back at the end of the week and find a whole lot of emails in the practice, even though they've organised follow-up of their patient. And it has also now incorporated a path to release from isolation, which then feeds back to the department. We recognise that it's an administrative burden, and we acknowledge going forward in the pilot that we have to look at the system and actually do what is more friendly in general practice. It's going to be a little bit easier now as the numbers dwindle, but we're very aware that there have been good points about it. The data that I showed you earlier was generated from Redcap. However, that it has been a burden to some GPs, and we have received quite a lot of feedback, words to that effect. Again, this is a little bit about Redcap, the data it captures. It really asks the GP to do a very quick survey about whether the person's improving or not improving, and at a point when the person is anticipated to need isolation, will start to prompt, does this person qualify for isolation release? Previously, this was something only done by the department, but they are keen to make this a clinical responsibility, as it is with most other diseases actually, but they do want that point of feedback back to them. And I think it's very appropriate that people doing clinical care who know when people stopped becoming symptomatic are actually the ones to assist with the release from isolation. This is just the system process for release to isolation, which has been really nicely done, but I note today that the federal government, the CDNA, have changed the release for isolation recommendations for hospitalised patients, which used to be an extra 10 days, and so we probably will feed that back into this when it gets updated in the Victorian contact tracing and isolation manual. So it's basically a 10 and 3 rule. People have had to be 10 days since the start of their symptoms and at least 3 days symptom free before release. And there's a few exceptions, especially immunocompromised. At the moment, it remains inpatient stay and a patient with persistent symptoms. And I'll hand over to Alistair to talk about what is a persistent symptom in his area, because obviously some patients do have things like anosmia for a really quite a long period of time. I just wanted to finish up before we ask for your feedback and questions, just to talk about some of the cases that we've seen through the centre, just to give you an idea. So a woman in her 90s who was discharged from rehab, COVID positive with no follow-up, was linked to hospital in the home. A woman in her 70s, very similar story, didn't actually refuse to go back into a hospital system, but she was linked with daily follow-up with her trusted GP. We've had hospitalisations of women in their 20s with confusion, a woman with hemoptysis, a man in his 40s with chest pain. There's many others. We've assisted a case who required hospitalisation, excuse the typo, who was very reluctant to leave his wife and newborn baby and toddler. We provided social support for the family so he could be sent to hospital because he was really quite unwell. We've linked quite a number of international students to care, high-risk patients into the virtual ward, and people who are homeless linked to GPs, opioid substitution therapy and other services. So the next slide is feedback. I mean, I welcome, again, some attendees would have participated in the program and had a referral and others wouldn't, but we do welcome feedback, and if you don't want to put your questions up now, we'd be very happy to have you email the PHN and they can pass them on to us. So I'm just going to pause there, Alison.
Nicole, can you hear me?
Yes.
Hi, it's Bianca from the PHN, everyone. We've just got a couple that have come, bits of feedback and questions that have come through on the question pane. So it was a couple of bits of feedback, I think, for the model that's come from Peter around just reinforcing the need for a clear handover, ideally by phone, giving patient status and expectations for GP care. So that's coming back to the point I think you raised and identified the need to make sure that handover is really clear. There was also a comment that Redcap can support text messaging. So certainly something that's something that the project group has been following up on in terms of it does have that capability, and we're just looking at that as an alternative to be able to send the Redcap surveys via text message rather than being reliant on email, which may help in terms of people being able to receive that in a timely way. There's a question, Nicole, around the role of testing in release from isolation.
Yeah, so I think this is very important. Most people do not need a test to be released from isolation, and a lot of people actually go back and get themselves a test, or their employer asks them to go and get a test because they think that's what they should be doing. And it often actually confuses the issue because they come back positive, but they're not considered infectious. So the testing is really only for people who are immunocompromised, because they can have prolonged excretions. So testing for release is actually not something that most people need to do. It's not recommended by WHO, by our guidelines, both nationally or our state guidelines. And I think it is very confusing to patients who want that kind of negative test to be told that they're cleared. And it's a conversation that you have to have with them about there being, sort of such little bits of virus but still left in their system, but they're not infectious. And I think, yeah, it's often asked for by employers as well.
Great, thank you. Another bit of feedback in terms of the model was around from Meredy. She's continued to receive emails despite completing the discharge survey twice, and just wondering whether there's anything that she's missed to ensure completion of that sort of discharge.
No, we actually had a meeting about this yesterday about that particular issue. I apologise for that, and I think what we're going to do is probably get you to email the PHN, and they'll forward it to us, and we'll try and cut it off, stop it. Yeah. Appreciate you being so diligent as to do it twice. That's great. But yes, and there was another issue today with Redcap, especially when someone was looking after a person in the community and then actually referred them into a hospital and then continued to get the Redcap survey. So look, I think this is all, we're very aware that there's an administrative burden, and this was a system that was set up but we need to test it going forward and see if it actually, we need to change the way it's done.
There's just a comment from Bernadette, which certainly the PHN can pick up, as just that point about publicising to employers and making sure we're getting the message out there that people do not need a test to be for that sort of that clearance. So that's certainly something that we're happy to follow up from a PHN perspective and make sure that's going out through communication channels. There is a comment from Mohammed thanking you, Nicole, and the whole project group for the work behind the scenes for the project. So a huge amount of work carried out in a very short period of time. There's a question from Roland. Who makes the decision that the patient can end their isolation? Is it DHHS always?
So no, this is in transition. So clinicians are allowed to make that decision. We've had that, you know, we've had it developed with DHHS in partnership. We want them, if you actually read their manual, it doesn't say that they have to do the clearance. It just talks about the clinical criteria for clearance. So it is possible, and there is now, the PHN does have a draft of a letter very similar to what the DHHS has used that you can put on your letterhead and give to someone. I think whenever you're concerned about, if you're concerned about the rules of isolation or whether the person meets the criteria, in the long run, the department actually want us to move to, like we would if we had a case of rubella or chickenpox or something and we weren't sure, actually ringing up and discussing with a infectious diseases or other specialist. And basically, I think everyone probably has had the experience of struggling to get through to the department line. So yeah, that's sort of where we're headed with that it will actually be a clinician responsibility.
Mm-hmm. And there's just a question, is clearance different at all for healthcare workers? Or is it the same process?
So my understanding at the moment is that it isn't any different for healthcare workers. And if individual sort of settings, you know, it's basically the same principle of infectiousness. Alistair, is there anything else that we should know about that with healthcare workers?
No, that's my understanding, Nicole, that they have the same criteria. There is no criteria, a need for them to be swabbed or any other special criteria.
But you do get aged care facilities asking for people to be swabbed, for example. So yeah, it's trying to discourage that actually.
There's just a question around, are patients being supplied with oxygen saturation monitors in the pilot?
Yeah, I'll speak a bit to that shortly.
Perfect, lovely. Thank you. Sorry, Alistair, jumping ahead.
Sorry.
There's a question around, I want to ask how the person who is isolating will confirm the person is no longer infectious. I might have confused that question. I think that's from Rujby. I'm not sure if you want to pop your hand up and ask that. You'll probably do that much more justice than I did, sorry.
So I think we've got two cases. We've got the person who's got confirmed COVID, and they follow the 10 and 3 rules. So 10 days since the symptoms onset and 3 days symptom free. Now, if the person is a close contact of the person with COVID, then they do get a test. If they remain asymptomatic, they do get a test on day 10 or 11. So they are remaining in isolation. Now, if you have a household of 5 and people are sequentially getting sick, you know, that person who doesn't get sick can remain in isolation for quite a while as various members of their household get symptomatic or get tested as positive. The clock resets for that person every time until they get COVID. And we've certainly seen that in large houses of international students where up to 6 members in fairly crowded conditions and often only sharing one bathroom, and it's basically gone through 6 out of 6.
And a follow-up to that question was around what's the best possible clearance method to identify that the infected person is no longer infectious? Is it a particular?
So again, it's about knowing their history, knowing their symptom onset, and then knowing that unless they're immunocompromised or had a very prolonged hospital stay, after 10 days since symptom onset and 3 days symptom-free, they are no longer infectious.
Thank you. There's a couple of questions relating to some DHHS advice, but I'm wondering if you'd like to move on to Alice's presentation, then we can come back to those specific questions around the advice that DHHS is giving out about a couple of cases.
Yeah, I think that would be good. We should move on.
Mm-hmm.
All right, so as Nicole said, the medium risk stream is within what we're calling the RMH Virtual Hospital, just because it sounds nice. And I guess it's still a model that continues to evolve. And it sort of started off as a 3-tiered system, with HIF being the most intensive, which involved daily telehealth to start off with, but in the period of highest likely symptom burden, having twice daily telehealth visits and the possibility of in-person review by clinical staff. And coupled with that, we were using are using remote monitoring in the form of SATS probes. So measuring oxygen saturations both at rest and with exertion, and also getting from that heart rate, temperature where that's available, and coupling that with a structured interview. And going down through the streams at sort of at the other end of the intensity is an outpatient telehealth model, which again goes from second daily up to daily reviews, with backup from medical staff, but with and calls being done also by nursing staff. And just go on to the next slide, Nicole. We're really evolving now, and I guess as we go through, looking at what COVID looks like into the coming months, and as Nicole mentioned, chronic disease or sort of management of chronic symptoms is going to be a big issue. So really looking at multiple clinical parameters that will allow us to track over time and sort of make a score from those numbers, and have clear escalation triggers to either higher up within the medium stream or to become an inpatient. So I guess the risk stratification really can escalate people for a couple of reasons. The first is because of age or comorbidity, and they're often picked up within that lower stream, the lower tier. And I think, as Nicole said, there's been quite a lot of flexibility within that model, and looking, there may well be GPs who are happy to have daily contact and are able to do that. But twice daily contact and remote monitoring is pretty hard to do as a single practitioner. And we have the advantage of multiple people and a number of different disciplines involved. We have involved our respiratory HARP team, and I think going forward, probably by the end of this week, we'll evolve the model. And so respiratory HARP will provide additional specialty support to that lower tier, and a step down option for the HIF appropriate patients. And going forward, it's very likely that we'll continue to have respiratory HARP involvement for those people who have ongoing and significant burden of symptoms. So the hospital in the home, or RMH at home team, already have a very large home-based model, and we really piggybacked on that and have slowly built that ward as the numbers have required. And so the initial consultation, whether that's in hospital or in the community, is in person by one of our medical staff. They hand out the oximeters, the other equipment. They educate them on using that and what to expect. And then, as I said, quite intensive twice daily phone visits or telehealth visits with a 24-hour contact for those people. So look, I thought I'd talk just a bit about what's to come, and I guess we're all a little bit in the dark about this, and we've all been so intensely focused on the acute disease, and rightly so. We know that at its worst, it's about as severe as viral infections get, and it's a really multi-system hyperinflammatory syndrome. And in fact, there's now been a sort of a new term phrase, the COVID hyperinflammatory syndrome. And while the disease severity, as you saw in those slides earlier, is largely determined by the respiratory disease, so the oxygen saturations, respiratory rate, the degree of pulmonary infiltrates on imaging, we know that people get a really wide variety of symptoms, and it often contributes to their severity. And I think it was really surprising to me on acute ward service how many people had other symptoms that brought them to hospital rather than their respiratory disease. There's a really great article out recently in the BMJ looking at the management of what they've termed post-acute COVID-19, and defining that as that period between 3 and 12 weeks, where after 12 weeks is considered chronic. And I'll talk a bit more about that in a moment, but I guess what we don't really know yet is who is going to develop long-term symptoms. There is quite a big sort of online support community, people calling themselves long haulers or long COVID, and there is quite a large lay literature, I guess, around this. There's more written in The Economist and The New Yorker than there is in medical literature at this point. Just on to the next slide. So we know that people can develop persistent symptoms even after very mild illness. The only significant published data we have, there's a couple of smaller trials as well, but there was a trial out of Italy where they followed 143 individuals, and it was about 2 months after their hospital admission, and only 12% were symptom-free completely at that point. A third had 2 symptoms, and more than half had 3 or more symptoms. And you can see in that graph on the right that really fatigue and breathlessness predominated, with nearly half people presenting with those symptoms. And nearly half the people had worse quality of life than they did prior to their infection. And I think, the symptoms that people present with can often really be broad ranging and not related to what we'd expect necessarily from COVID. So what we know about mild illness is a bit harder to pin down. There's a big UK COVID symptom study using a smartphone app, which is recording sort of self-recorded symptoms. There's nothing published formally as yet. There's a lot on their website. It's an ongoing study, but the article in the BMJ did talk about some of the results from that, suggesting about 10% remain unwell beyond 3 weeks. And I think that represents that difference in prevalence represents the difference in disease severity at presentation. And I think that's fairly consistent through the literature. There was another study out of the States where they did telephone interviews 2 or 3 weeks post-infection. And I think the really surprising thing out of that was that even in younger people, about 1 in 5 hadn't returned to their health, the usual state of health at 3 weeks, and about 1/3 overall across the entire population. We know from previous coronavirus infections that it really can last quite a long time. There's quite a lot of data out of Hong Kong and Canada. A study published a few years ago looking at people a year after infection, and about 1 in 5 had a reduction in their 6-minute walk test, and a significant proportion had reduced quality of life. There's quite a bit of literature talking about sort of post-viral, post-infectious, sort of fatigue type syndromes. And this study nearly 10 years ago showed even up to 18 months after SARS infection, a syndrome of fatigue and myalgia and weakness and non-restorative sleep. And the other literature, I guess, is around post-trauma type syndromes. And I guess if we think about for people who are socially or medically vulnerable at baseline, that constant threat of infection is really significant. And a study in healthcare workers showed that there was quite marked physiological distress and stress ongoing even a year after the outbreak of SARS. So what I found this resource from the Primary Care Respiratory Society in the UK talking about what is a reasonable expectation for symptomatology. And some of this is based on COVID-19, but a lot of it is based more on SARS and MERS. And talking about the predominant symptoms, muscle aches, chest pain. Sputum production is less of an issue, although it seemed to be early in the pandemic. But those things lasting perhaps the first month or so. Cough and breathlessness lasting much longer, perhaps 6 weeks, and I think that's probably fairly generous. I would say even 8 weeks or more. And by 3 months, the majority of symptoms should have resolved. Fatigue is likely to still be present, and in fact, there's a reasonable literature suggesting that fatigue can last 6 to 12 months in some people. And I think there's some literature suggesting that by 3 months, perhaps 2/3 of people will have resolved their symptoms, perhaps a bit more. But in 6 months, by 6 months, we'd hope that most people had. And this does rely on the idea that they haven't had other complications. So those people with critical illness myopathies or neuropathies from prolonged hospital stays, or indeed chronic lung disease or other complications may well have longer symptoms. I put this in not because I think we should be using it. It's a really nice scale, but it hasn't been validated after this publication. But I think it just talks to the kind of things that we need to be thinking about. Because I think respiratory symptoms are important. Clearly, as a respiratory physician, I think they're very important, but they're probably not the thing that is going to affect most people. And ongoing fatigue, ongoing pain, and ongoing mental health issues, I think, are really going to be predominant going forward. So when it comes to respiratory disease, I guess, there is certainly going to be a symptomatic burden, people presenting with cough, presenting with ongoing breathlessness, both at rest and particularly, as Nicole mentioned, with exertion. But I think we also obviously need to keep in mind what sort of things are we likely to see after people present with COVID. And I think all the evidence to this point would suggest that it's really only people who have significant pulmonary infiltrates, and perhaps only really those with severe disease, who are likely to have structural lung disease. And I think that the delineation of people with moderate disease needing to be in hospital is a fairly soft delineation. And I think we saw a number of people or have seen a number of people who under normal circumstances would have been admitted to hospital, but for whatever reason have not felt able to go to hospital, and so have been managed in the community. And so I think while it's unlikely that people in the community will have developed significant structural lung disease, it's entirely possible that we have not picked up people who have had moderate or severe disease and have just struggled away at home. So we know from recent study out of China that at 3 months post-COVID, and this is people who had been admitted to hospital, about 70% had persisting radiological change, and about a quarter of people had lung function abnormalities. We'll just go on to the next slide there, Nicole. We know from the SARS and MERS outbreaks that persisting lung function abnormalities are common. They're often mild. Usually they can be a range of things, but most commonly a reduction in diffusion capacity. But the functional impairment is often disproportionate to the physiological abnormality. And I guess, you know, what's probably more important to everyone is managing the symptoms rather than necessarily a mild physiological or measured abnormality. We know that people with most severe disease do develop ARDS. We can argue whether it's the same as other ARDS or not. But there is certainly an occurrence of pulmonary fibrosis with ARDS, but it's thought to be largely related to ventilator associated injury rather than the underlying ARDS. But certainly there is, from the ARDS literature, suggestion of impairment both in physiological terms and functional terms out as far as 5 years. And also importantly, changes in neuropsychological function and quality of life out to that time as well. So I guess, you know, we don't have any guidelines at this point. The National Task Force hasn't got any post-acute COVID guidelines at this point. The British Thoracic Society has put out some recommendations for follow-up after hospitalisation or people with moderate disease. And they're suggesting a clinical review within 6 weeks, and then a chest X-ray at 8 to 12 weeks. I think they've said 12 weeks. And I guess they've stretched it out beyond the usual 6-week recommendation because of a concern about infectiousness. And I think, you know, in response to a question Reg Beer asked, you know, we don't know what the best test for infectiousness is. You know, we're making a decision on clinical grounds with the idea that people are unlikely to be infectious, but we can't say for sure. But we don't think that, you know, even if people are shedding small amounts of virus, even if they have detectable viral RNA on a swab, we don't think beyond that point that they're infectious. The BTS guideline also suggests that people who have had moderate disease who haven't required hospitalisation, but have had a suggestion of a change on their chest X-ray either clinically or performed during their illness, that we should consider doing an X-ray at 12 weeks. And I think further investigation is really as clinically directed, and I think it's, you know, I think you guys are in primary care in a really difficult position to try and, you know, work out in these people who may well have really prolonged symptoms, who and when exactly to do those investigations. And I think in terms of prolonged symptoms, the ones that I guess we're more concerned about are symptoms that get worse rather than better over time, or develop as new symptoms after recovery. If people have had moderate and severe disease, if they've been known to have pneumonitis or if they've been known to have some myocarditis, then clearly they require a closer follow-up and review. But I think even in people who have not had hospitalisation, if people develop breathlessness, ensuring that they are not anemic, that they don't have other physiological derangement that may explain that, undertaking a chest X-ray as a baseline, and then spirometry, diffusion capacity, and measurement of a 6-minute walk test really aids in, I guess, establishing whether there is a physiological abnormality, because we know that the symptoms may not match up with any physiological abnormality. Echocardiography is obviously going to be important if there's any concerns about structural heart disease, and if there are persisting abnormalities on a chest X-ray, or if there's any question about the chest X-ray, or indeed if there are concerns about venous thromboembolic disease, then a CT is recommended. So look, I think in terms of management ongoing, I'm sort of hesitant to put this slide in because I don't want to be trying to tell you what to do. You guys do this much better than I do. I think one of the things that we had a session talking about mental illness in COVID disease, and one of the things that one of our rheumatologists talked about was a specific exercise prescription. So I've often suggested that people just go out for a walk, perhaps suggesting grading that. But her recommendation was actually to give a specific exercise prescription and treat it like a prescription rather than a recommendation. I think dietary support is going to be important. Our dietetics team has put together some resources really for the acute phase, but I think in this post-acute phase it will be important as well, and we're working to get that available through health pathways. There's been quite a lot of talk about regular breathing exercises. We know that in people who have persisting breathlessness and feelings of unable to get their breath, that they often revert to non-diaphragmatic breathing. And certainly in the BMJ article, they talk about just very simple regular breathing exercises with sort of the expiratory phase twice as long as the inspiratory phase, whether we're using that or box breathing or something like that. I think promotion of good sleep hygiene is really important, and I think certainly in the context of mental health issues, this is really critical. Clearly, all the other chronic health conditions people have aren't going away, and management of those is going to be just as important now, if not more so, than before. And I can't stress enough that I think psychological support is going to be really important, and I think the majority of that will be managed by primary care, but I know there are new provider or new telehealth item numbers for psychology, and so there may well be psychology support for people as well. So look, this is the infographic from that BMJ article, and I really, it is summarised. There's an article in the RACGP newsletter talking about the article, and they really hit upon the key points of the article. But it's not very long. It really is a good read in terms of things to look out for and how we might help people. And that's it from me, I think, unless Nicole's put anything else on the end. Oh, there we go. Nicole's got some more slides for herself. There we go.
Sorry, that was a bit unfair on Alistair. I put that in at the end. He didn't even know it was there. Apologies. Yeah, look, that was all. The next slide I thought I'd actually taken out, but there you go, I didn't. I just wanted to very briefly mention health pathways. Bianca mentioned them earlier, but that there is an increasing number of different health pathways for that are COVID related, including the one for the Northwest Melbourne pilot. And they have the risk stratifications, and they have how, you know, various drop downs as are the health pathways format. And these are the critical numbers, and there's also a really good infographic from the PHN, which many of you might have received if you're part of the program, but I'm sure the PHN will be happy to circulate about it. Just to keep everyone updated, what else is happening? So, I mean, we mentioned this last time that Djerriwarrh had a program, that we had some ongoing presence at the public housing estates, and that there was a COVID app. There is the Department of Health are looking at a rollout of this pilot, so looking at a similar model in different, looking at really hospitals as districts, which they're not really actually in our system. It's more of a New South Wales idea, but again, trying to get care for most Victorians living with COVID. I think this comes at the end of the wave, so that's a little bit unfortunate, but I guess it prepares us for subsequent outbreaks and hopefully a more primary healthcare engaged way of looking at care of people in the community and not just compliance. I think we should stop there for questions. I had an acknowledgement slide, and these are just some resources. I mean, there's others, but the BMJ evidence group have done a lot of work, as well as our COVID evidence group. There's a good podcast on post-COVID syndrome on the BMJ website with the paper and that infographic, and this is the RACGP resources as well. So big thanks to you, the GPs and practices who participated and been, I like the way I've spelled that, patient with the pilot process. That was meant to be, anyway. This is very much I was going to say it's the end of the week, but it's actually only Tuesday, so I'm clearly, yes, getting ahead of myself. Anyway, I thought we should ask if there are any more questions, and to Alistair particularly about post-COVID, and to the wider team or the PHN.
Thanks, Nicole. A couple that have come through specifically for Alistair's section. So you mentioned spirometry, Alistair, and someone's commented that was quite interesting. So GPs have stopped doing that altogether based on DHHS advice. Is that right?
Yeah, look, so spirometry is kind of our bread and butter, and it's been very hard for us to stop it. You know, the recommendation from our professional group was to limit it as much as possible. And I think, you know, we have really cut back. You know, our lab is doing, you know, perhaps 10% of its usual work. And I think, you know, we speaking to people the day before they come in, you know, doing a survey over the phone to ensure that they haven't got any symptoms of COVID, that you know, they're temperature checked as they come into the hospital, and all our staff are wearing masks and face shields while doing the testing. I think it is, look, you know, I'm not going to suggest that people are doing it in their own practices. I think that has to be something that people decide on locally. We are doing very limited amounts, and certainly we are doing it in people who are post-COVID for persisting symptoms.
Thank you. Just another one following on from that. There was mention of a chest X-ray in one of your slides. Private imaging places hesitant to do chest X-rays on post-COVID patients. Is there a particular place that GPs should be looking to send these patients?
I wish I could answer that. I don't know. I know that, you know, there's been you know, a great deal of infrastructure put in place to keep private radiology from having an outbreak. You know, We are doing imaging in the hospitals, but clearly, if we can avoid people coming to hospital, that is preferred. I don't know the answer to that, I'm afraid.
And just a question from Isabella, what tests can we do as GPs of a patient who's presenting with post-COVID symptoms but never tested positive on nasal swab or never got a test? Should we do serology?
Look, it's a really good question. So there are now serologies that are being rolled out. I know that we're starting to do serology. I think we started today within the health service. I don't know if they're available outside. And I guess, I think realistically, if people, are now clinically post-infection, but they've had symptoms that would be consistent and they now have a syndrome that would be consistent, then we should probably just be treating them as that at this point. I don't know, the studies, I guess, of seroconversion prevalence would suggest that not everyone is seroconverting. So I think even if someone had negative serology, but had a syndrome consistent with it, we'd still approach it in the same way.
Thanks. This is probably a question for Nicole and Karen from cohealth. How far back does the tracing team go for any positive case, and is it different if the positive case is a health worker or to the panel in general?
So to be clear, we didn't take over contact tracing, we took over assessment and management. But we did, through that process, find people who'd been missed by contact tracing is probably a bit too strong, but certainly people who revealed to us issues that we could then advise them in terms of preventing onward transmission. The data we got from the beginning of the pilot went back about 10 days before the pilot started on the 3rd of August. And we're hoping that now that some data issues have been fixed, that we'll get the last, well, certainly any active cases that remain in the catchment. But it has been an ongoing complex issue.
And just a question for the whole panel, not sure who wants to take this one. Is there any evidence for reinfection?
There was, I saw one case has been reported out of China. I don't know if it was today or yesterday. There was certainly someone who sort of, it was 4 months between infections. So there certainly is a suggestion whether, that is going to be sort of show out to be an ongoing problem. I don't really know, but I think what we have seen is that there is a rate of non-conversion in serologically, but we don't know is the short answer.
Thanks. A few more questions coming through. Not sure who's happy to take this one. What's been done to get positive test results to patient GPs? We can jump on this immediately and screen for high-risk transmission situations. An example of a GP who notified a meat distribution plant of positive cases before the DHHS.
Yeah, so there's quite a few things being done. So the department is now asking that all testing sites collect GP details. Now you'll appreciate that is possible in some circumstances, but in very high volume testing sites, they're saying that's not always possible. But they are being asked to, if they've got COVID positive and the person has a regular GP, to notify the GP at the time they're notifying the patient. I have noticed that happened to us yesterday for the first time at cohealth when we got a notification of a positive case. It was actually not a true positive, it was a retest on an already positive. being discharged from Western Hospital. So I think that is starting to happen. I think this has been a real weakness in the system to date, and I think it's very important because GPs know their people, they know their communities, and they do have the ability to understand their own local epidemiology, sometimes better than a centralised contact tracing service.
Thanks, Nicole. Just a question regarding the discharge criteria. This has come up for a couple of the sort of symptoms. A patient will not be eligible for clearance if they have persistent symptoms. Is myalgia or persistent loss of taste or smell considered as a persistent symptom?
So look, the wording of the clearance document is respiratory symptoms. And I guess, you know, so Peter McIsaac asked about you know, ongoing breathlessness, and I think that that's really difficult if we're saying that breathlessness is going to be lasting, you know, possibly months. We would think that they would still be able to be cleared from isolation well before that has resolved. And I think it's one of those cases, and this is an ongoing battlefield, is who should make that decision if it's not clear. And certainly the position at the moment is that should be a discussion with DHHS. And I think if someone is not febrile, if someone is clinically improved, but has some persistent exertional breathlessness, I suspect DHHS will be happy to clear them, but I think it's a decision that needs to be made by them at this point.
Thank you. We've got a few other questions, and ones we can't get to, we'll try to respond. There's a couple of case sort of questions that have come up. So there was a patient who presented today, day 21 post positive COVID test, cleared by DHHS a week ago and has been in the community. Today came in presenting with bilateral upper limb paresthesia and states feels brain is slow. The right side can't keep up with the left side, ongoing poor appetite and fatigue, pulse rate 110, chest pain, regional Victoria. It sounds like the patient's from regional Victoria in foster care, non-English speaking and hesitant to attend hospital. Any suggestions from the panel? Sorry,
look,
that was a long one.
Yeah, look, it sounds like they need to be assessed in person. I mean, I don't think there's an easy way of trying to tease that out remotely, and I appreciate convincing someone to come into hospital, you know, particularly when there are difficult social circumstances, is not straightforward. But I don't think there's a safe way of assessing that in the community. I don't know if Nicole wanted to add anything to that.
No, I left that one for you, Alistair. Tricky one.
Yeah, thank you.
Are we worried about thromboembolic kind of issues with this kind of person?
Look, I think you'd have to be. You know, we know that people are, you know, really highly prothrombotic in significant COVID. So I think that has to be a really significant consideration. Yes. There was also a question earlier in the stream about whether we should be giving DVT prophylaxis to people, to elderly people who are immobilised at home. I don't think we have, you know, we don't have any guidance on that. I don't think we have any evidence to suggest that is the right thing to do. I think it is, you know, we don't have any evidence to guide us really at this point.
Thanks, Alistair. There was another case, client's partner was advised he needed a final COVID test on day 19 after testing negative on day 11. Patient was discharged on day 18. It seems strange to give her permission to resume normal activity, but the patient was not cleared for another 24 hours. Was he still in isolation for the 24 hours despite her release from isolation? The timing of the final COVID test seems strange. Not sure if anyone, that's a comment or a question, or any comments from the panel around that? No?
Yeah, look, we've found some various timings being a bit unusual, and sometimes it can be related to the department not getting the symptom onset stuff right, or they're being concerned about that person being a contact of someone else. And our most recent is that we had someone who was still in isolation day 30 and hadn't been released from isolation, even though that was probably at least 2 weeks overdue. So I think with that, some of those things I do encourage to ring the 1300 number and press 0 and then press 1, so you don't have to listen to all the options. Actually, no, you've got to check that again, because apparently they've just changed their options. It used to be press 0, press 1, and then you could get through to someone, and then you could make a query about an isolation call. We have queried a few isolation releases and actually really haven't had anyone put back in isolation, even though one person had onset of symptoms, was asymptomatic for 12 days and then had a classic COVID illness. So yeah, look, there's a lot of exceptions to the rule. I don't think I'm answering your question, but I'm just saying, yeah, it does seem a bit unusual, and I encourage you to ring and have a chat to the department if you think, or ring and talk to infectious diseases crew at the hospital and talk it through with them.
Just a question, do we know the reason that some patients are asymptomatic?
Age is a big part of being asymptomatic, so the younger you are, the more likely you are to be asymptomatic. I'm not really sure of anything else, particularly that we've identified immunologically. I'll hand that over to the respiratory physician.
No, not as far as I know. I think everyone is trying really hard. It would be really, obviously be something that would be really useful to know, but I don't. No one has put anything plausible up as yet.
There's a question, Alistair, that's probably more for you. What's the current treatment protocol at hospitals? COVID.
Yeah, look, it remains largely supportive in those that require oxygen. They will almost always get dexamethasone. It's very good evidence, or the best evidence I guess we have, for reduction of need for ventilation and mortality benefit with the use of dexamethasone. There is still some remdesivir around, and some people will get remdesivir as well. It's a 5-day course intravenously. And there are a number of clinical trials going on looking at other treatments, but they're really the two major consistent treatments being used at this point.
Great, thank you. Just another question in terms of contact tracing. If a frontline worker has tested positive today, how far back in terms of days should contact tracing be?
So
my understanding,
2 days, yeah. Sorry, you go, Karen.
So I think it varies on workplaces. Some say 48 hours and some others say 72. I don't know if is there a consensus?
Yeah, I'm not sure. Certainly at the Royal Melbourne, it's 48 hours, but I don't know if that's consistent across all workplaces or all healthcare workplaces.
There's just a comment that's come through that there was a recent paper on low vitamin D levels associated with worse outcomes. Does anyone want to comment on that?
Unfortunately, the low vitamin D levels is associated with poor outcomes in lots of different diseases. But unfortunately, we haven't seen in almost anything improvements in outcome with vitamin D replacement. So it probably relates to as a sort of an indirect marker of general health to some degree. So I'm not surprised that that's been shown, but I think it's unlikely to change with supplementation.
Great. I think, unless I have missed anything, that's mostly all of the questions. There's a few thanks for a great presentation and all your work on the project. Does anyone have any final questions? You can either put your hand up or type that in. Oh, sorry, there was just a question. I'm not sure Karen or Nicole or any of the other people on the call know. Does anyone know where people can get a fit checking on the masks that they have? So are those masks a good fit? Or does anyone have any tips that they can share on that?
I think it's more about whether you can feel air escaping when you're breathing. So, I mean, first of all, it's looking to see if there are any gaps, and then to see if you're noticing air escape from kind of the main areas would be from the top of the mask or the bottom of the mask, but I certainly don't know if there's a particular fitting check. Alistair, let it handball it to you.
Yeah, look, I'm not aware of anywhere that's doing fit checks routinely. They're certainly not being done in at the Royal Melbourne. I mean, there's lots of chat about it. I think the anaesthetists have done a bit of work on it locally, but I don't know anywhere that's doing it routinely. I know, there are certainly places elsewhere, sort of in the States. I know they do regular fit checks, but it's not something that's been routine here.
We have told a whole lot of people to shave off their beards, though, haven't we, Alistair? That's been one part of the checking has been telling Royal Melbourne staff to shave their beards off.
Yeah, that's a pretty easy one. Masks won't fit on beards at all, really.
Great. Okay, that looks like all of the questions. Not sure if the panel wants to say anything before we finish up.
It's great to see so many attendees. I can see people have gone off to get dinner now. We've sort of dropped from 102 to 83. So thanks all for your time. And please continue to give us feedback, and we'll keep on trying to improve what we're doing.
Alison, I'll just hand over to you to finish off.
Yeah, no problem. Thank you. Thanks so much to our presenters, and certainly thank you to everyone who's dialed in and provided some really good comments and provided some great questions for discussion. I hope that you all took a lot from tonight's session. So just a reminder that we are planning to continue to run these sessions. At the moment, we'll be looking around a fortnightly sort of basis. But happy to take feedback. We've got a bunch of different topics in the pipeline, but would also love to run sessions like this where we can just have some good question and answers and case discussions as well. So please keep an eye out for those, and we will keep you posted on when the next sessions are scheduled. And also just a reminder that in your inbox, probably right now, you should have a post-session email with an evaluation link if you would like to go in and spend just a couple of minutes to complete that for us and then provide any comments, feedback or suggestions. But I think that's it. We'll probably let you go. Thank you so much for hanging in there, and hope you enjoy the rest of your night, and you have a great week. We'll see you next time. Thank you.
Thanks all. Good night.
Thanks.